It's what we've been waiting for, isn't it? Right? So I do male and female reconstructive urology, which puts me in a little bit of a special situation when we talk about cancer survivorship and some of the events that occur around erectile restoration and all the other type of urologic complications. And that's primarily what I've been tasked to discuss with you today is erectile restoration. But I tell you, these are the conversations that you have to have one-on-one with a patient. Now, I'm often in my clinic, I'm a visual learner. I'm not a very good auditory learner at all. We all assimilate information in different ways. I'm a visual learner. And so I have a lot of diagrams, and when I go and I give talks like this, I've got a lot of slides, and so this is a little bit of an uncomfortable situation with me. You're going to have to bear with me. I did find one thing out in the lobby, though, that I can kind of use for part of the talk. Actually, when we talk about survivorship, that's a remarkable thing. Right? Thanks to my oncology colleagues, we get to have this discussion. That you come into my clinic and you're ready to start to live and regain function in your life. And so it gets a little bit irritating when I hear, well, Melissa, you do benign urology. There is nothing benign about these quality of life issues. They have tremendous, tremendous impact. And I think that we need to appreciate that and we need to talk about it up front. And so the way I was told by Daryl that you're probably a little more sophisticated audience than what I'm accustomed to having in Nashville. Has anybody been to Nashville? Yeah, okay. You get it, right? But the way that I've kind of structured this conversation is the types of conversations that I have with my patients in the clinic. Like, what are the questions that they're coming to ask me about? We're not going to go through the entire litany of the erectile dysfunction guidelines from the AUA, although they exist and you can all get them online. But the first thing that I want to tell you about is you have to engage the right person to have this conversation with. This is really an intimate discussion. You have to find a provider that resonates with you because this is going to be a process. It's not going to be a one and done that you have a condition and we're going to work through it in a quick surgery. This is part of your life moving forward. And so if you can engage the appropriate provider who has not just clinical knowledge, but has the compassion and that you can speak with openly, that's the most important aspect about your sexual recovery. So some of the things, I want to go through a list of questions that I find my patients ask me, and maybe you will have asked them too. So the first question is, what should I know about my erectile function before my treatment for prostate cancer? And for everyone that was here earlier and heard Deborah Jennings speak, the things that she wished she knew and that Dale wished he knew, first, it's that you have to know that this is going to have an impact. Right? There's nothing that we are going to do to treat prostate cancer currently that is a friend to your erectile function. So everything is predicated on where we start today. And that means that what we do now means we have to have asked the question before we start, right? And so these are important things for you to have that discussion with your provider about before anything even begins. There was a lot of vogue for many years about a concept of prehabilitation or rehabilitation, of utilizing medical therapies in order to preserve function. And the data hasn't been really robust to support that, and it may be costly, and there may be side effect profiles to it. But the fact is that it engages you in doing something proactive to help. And I think that opens a conversation and it opens a dialogue with your provider that can be very powerful. But it keeps you in track on how you want to progress through the process. So question 2, why do I have these issues? My surgeon said that I got a nerve sparing procedure. Right? Said they spared the nerves, so why did this happen to me? Right? Some of it may be that it's just poor luck, right? Some of it, though, is that the fact is there's many, many different factors. When we talk, people say all the time, oh, women, you're complicated. No, let me tell you what's complicated. Erections. Men are complicated. So this requires an intact neurovascular pathway that runs from the deep brain all the way through all the peripheral nerves, including the cavernosal nerves that serve the blood supply to the penis. It requires nitric oxide, everybody's favorite, trendy molecule. It requires, well, that's true. It requires that there's many other factors at play. We just heard about the impact of things like diabetes, the impact of hypertension, the impact of all these other things. And guess what else has happened during that time? Well, it's called aging, right? And that impacts everyone. It's interesting. There's a lot of anatomic proximity, but some of the other factors that probably end up causing post-prostatectomy, post-radiation therapy, erectile issues have nothing to do with that local nerve supply and local blood supply. So many other factors are predicated on this, and we can't just assign it to the scissors going in the wrong place during your operation. The other aspect that's kind of interesting is orgasmic function, and this was just briefly touched on. But orgasmic function actually goes through a completely separate pathway than erectile function. Now, men combine these, during your entire sexual experience, but the fact is that you can have orgasm, most likely not with ejaculate, but you can have orgasm without erections. Now, it depends on what your conversation is going to be with your sexual preferences, but it's always a possibility. The third question is, well, I've made this decision, now where do we begin? And I think that the things we begin with, of course, are these lifestyle modifications. That's going to be our baseline no matter what, ensuring that we have done everything we can to preserve, because you're alive now, you've survived prostate cancer, or even if you're in the midst of active treatment, we are looking forward, we're looking towards the next step. So we want to do everything we can to accelerate that and create a system of health, and that includes diet, exercise, control of hypertension, and diabetes. So that's number one. And then number two can be anything you choose. We have a whole suite. Most people walk through least invasive to more invasive, but that's not right for everybody. There'll be men who want to move forward to more advanced therapies early on. And once you've had a good shared decision-making process and an informed discussion, that's fine. That's completely appropriate. So it's all going to be the conversation of what your expectations are, and then what we can bring to the table to make that happen. So you should be very, very clear with your treating urologist exactly what your goals are and how quickly you want them to occur. So when we give you a treatment that may have a time course, be very defined. How long are we going to go through this before we move to the next step? Most men start their erectile recovery with medications. Now, I know that I've got some gray hairs under here. My hairdresser won't let you see them, but I've got them. But I see a few others in the room. Who remembers the world before there was Viagra? Right? Okay. And who remembers what people used to think about erectile dysfunction before Viagra? Right? Before we understood as a community what it meant to have a physiologic metabolic process that ended up with difficulties with erection. So frankly, these medications have changed our entire conversation about men's erections from a social perspective, and that has been just dramatically wonderful for us in urology to be able to help. And most men will start their journey with medical therapy, with pharmaceutical therapy. And so the question I get is, well, I tried it and it didn't work. Right? Okay, well, why don't we talk a little bit more about that? Because it's all about how you utilize those medications? How often? What dosages? What were you doing around that time? Did you have high-fat meals? Did you have, alcohol associated with it? So many other factors go into play, and oftentimes it's just a matter of education and re-education for you to be able to successfully utilize a therapy that's as minimally invasive. What kind of side effect profiles did you have from it? Is that going to stop utilization in the future? So paying very close attention to how you're supposed to utilize medications can often end up with very good outcomes in the end. And then for men who move to things like injection therapy, and I've heard that most men in this audience have very sophisticated knowledge of injection therapy. My patient population may not be quite that, but they come back to me and say, well, you did it in the office, you trialed in the office, everything was great. And as a matter of fact, I had one couple who said, yeah, Dr. Kaufman, that injection, it cost me $120. I'm like, what? I said, well, we do it at a compounding pharmacy. They're expensive. Insurance doesn't pay for it, but it shouldn't be $120. She's like, yeah, it was the hotel we had to stop in on the way home from your clinic. That was the problem. I was like, well, okay, that's good. But we got home, and then it never worked again. I couldn't get it to work again. So it's very, this is one of the aspects to utilizing injection therapy. Come back and let's go through the process again. Let's try to figure out a way that if we know the medication is going to work for you and you think that this is going to be a good option, that of course means that you're not ever going to be anywhere without a refrigerator or freezer, or that you don't have a lot of pain that's going to require we modify your therapy. But if it's going to be a good option, then oftentimes just further instruction and counseling can take you a long way with these. And we want to be very, very careful about prolonged erections with any of these medical therapies, because if they happen, it's not that we can't treat them, but if they go on for too long, there can be some very severe complications, including permanent dysfunction. But the worst part is that you show up in the emergency room and my intern is down there doing things to your penis that you don't want, right? So the next question is, well, even when the injections worked, doctor, my penis, no one told me that my penis was going to be smaller. It was shorter, thinner, less girth. What happened to my length? And how do we get it back, right? So there's a lot of plausible explanations for what can happen to penile length following treatments for prostate cancer. And one of them that we just heard about, right, nocturnal erections. So this is Mother Nature's way of continuing to cycle these tissues and stretch them out every night. And when we don't have that, it's potential that there can be scarring and fibrosis in those stretchy erectile bodies. It turns out that when we look at the data across the board, there's not a very good, robust set of information that supports this. Most of it is very modest. So some of the things that we have to understand is setting those expectations of where we were to start with, the other things that have happened, what we perceive as normal for you, and what we are going to be able to regain. So that is a very delicate conversation that has to be done one-on-one, where we open up those doors and actually look and determine this is what we have and this is what we're going to be able to achieve. But you have to set some very realistic expectations around that, because this is one place. I know we spoke about Dr. Google earlier in the day, right? This is one place where Dr. Google does some very, very predatory things. And I can't say that strongly enough, that there are many opportunities out there for mayhem, not just on your wallet, but also on your psyche and on your sexual health. Because promises that are made to you on a website about expectations that seem too good to be true are too good to be true. It's just that simple. Because trust me, I adore my patients. And if I had something that was that magical that could help them, don't you think I'd be using it? Don't you think I would? Like, I took a Hippocratic oath to do the right thing, right? So you want to think about that very carefully. It doesn't mean you can't bring it up to me because I'm going to give you my opinion, and it's my opinion, and that's why you came to see me. But certainly be very, very careful of those types of predatory behaviors. The next question is, well, okay, we've gone this route. Is it time for me to get an implant? The time for you to get an implant is when you feel it's the time for you to get an implant. And that's any time that you want it. As long as you've had a thorough discussion, the risks and benefits of doing this types of invasive surgery, then it's time. It's time to move forward. There's no, aside from artificial urinary sphincters, there's no more gratified patient population that comes back and says, God, I wish I'd done this earlier. I wish I'd known that I could have this level of spontaneity and rigidity and sustain a lot earlier, because I've lost 8 years of my sexual health and my sexual life worrying about something that we could have treated more aggressively, yes, but more definitively a lot earlier. Question 8. What about all these other therapies that I read about on the internet? Shockwave, stem cells, platelet-rich plasma. Now, I don't really know what the dark web is, but I know it's out there, right? And you can get all these things probably today, probably right around the corner here in New York City, for whatever you want to pay for them. The Sexual Medicine Society in North America just wants you to know they're all experimental. And outside of clinical trials, the best thing that can happen is that, again, you take a big toll on your wallet and that it doesn't work. The worst thing that can happen is that it's dangerous because they're unproven therapies and, again, predatory behaviors if you're not done in an appropriate clinical trial. And then the last question is, well, I'm moving forward with surgical therapy, or I'm trying to get some of these other things taken care of. Well, what do I tell people? Like, what do I tell people on my job? What do I tell my colleagues or my friends that is happening? And, I tell my patients, well, you tell them that I've had a complication from my cancer that I need to get taken care of. Nobody asks another question. They don't ask another question of him, never. So I encourage you, for those of you who have partners, to bring them along for these kind of conversations, because it can be very illuminating. They're the ones earlier, like Deborah, that took notes and remembered what was actually being said in these conversations. But we can also help. It's a bonding experience to go through some of the process of erectile restoration together and really help a couple recapture that level of intimacy in their relationship. So I look forward to your questions. Thank you for having me here.